Thank you for joining us for today's webinar, Palliative and End-of-Life Care at the Population Level. My name is Lee Montville, and I'm the Director of Special Sales and Business Development at Springer Publishing. Today's presenters are Alyssa Erickson, currently serving as Chair and Professor in the Department of Nursing at California State University, Monterey Bay, and Barbara Nitz, Senior Contributing Faculty Member at Walden College of Nursing in the doctoral program on a part-time basis and full-time Assistant Professor in the Advanced Practice Division at Rutgers University, the State University of New Jersey. Both Alyssa and Barbara are co-authors with Ann Curley on the recently published Population-Based Nursing 4th edition. Before we get started, I want to mention that this webinar is being recorded, and if you miss any portion of the presentation, you can find the video on www.springerpub.com 5 to 7 business days post-event. And if you have any questions, we ask that you please type them in the Q&A box on your Zoom control panel, and I'll bring them up at the end of the presentation. If you forget to ask a question, there'll be a brief survey sent at the end of the webinar, and you can include your question there. Now, without further ado, we will turn the time over to Alyssa and Barbara.
Hi there. Good afternoon or good morning. Thanks so much for being here today. For the first part, I'll be presenting on these objectives, and then Barbara will come in with the last part of the presentation. So for this first part, I'm going to go through distinguishing palliative care from hospice care, defining social model hospice, identifying some interventions to address social determinants of health from a recent exemplar, and then describe key learning lessons from this exemplar about the process of developing a social model hospice. So this definition for palliative care comes from the National Consensus Project for Quality Palliative Care, which published the clinical practice guidelines, which are accessible online. Palliative care really is seen as a model or a philosophy of care, and it's focusing on expert assessment and management of pain and other symptoms, assessing and supporting caregiver needs, and then coordinating care. It's for people with serious illness. It's really about symptom management, quality of life, and attending to the stress that an illness can have. It's a very holistic type of care. So it's focusing on physical, functional, psychological, practical, and spiritual consequences of that serious illness. It's a person and family-centered approach. And it's really intended to be provided concurrently with curative therapy. And this is the main difference as we turn to hospice care. So hospice care could be seen as kind of a segment of palliative care. It's a specific type of palliative care to individuals with a life expectancy measured in months and not years. And it's giving patients and families expert medical care, emotional and spiritual support, and improving patient and family quality of life through a team-based care. And the core of this team-based care includes physicians, nurses, chaplains, social workers, and volunteers. And then the families are really defined by those who are closest to the patient, typically those involved in the care and the concern of the patient. And really importantly is that in the United States, the hospice benefit is through Centers for Medicare and Medicaid Services, or CMS, and it's providing reimbursable care for people with a life expectancy of 6 months or less, so right towards the end of the illness. And this figure is depicting how palliative and hospice care coexist together on that illness trajectory. So you'll see palliative care is provided concurrently with the disease-modifying care. And then hospice is really right towards the end in the last few weeks or months of life. So with that 6 months prognosis. And also that hospice extends after the death and provides bereavement support to those closest to the patient. And the overall focus of both is about symptom management and quality of life. I just want to note that this figure is from California, the Senate bill, which was outlining reimbursable care for people with serious illness. So taking it outside of hospice, right in the end, but really for palliative care, what type of services could be reimbursed. So palliative care largely is provided at the individual and the family level. However, there's discussions for how to offer it at the population level. So Casper and Antenatal published this perspective piece in JAMA 2016, and really discussing that the goal of population-based palliative care should be to promote optimal well-being in the face of serious life-threatening illness for patients and their families. They're looking at the definition of health from the WHO as complete physical, mental, and social well-being, but then extending that for population-based palliative care to include members of an individual's social circle who are also affected by an illness, so into the community. And the aim is really to change the culture of death and dying. So at the population level, there are inequities at the end of life. So some of it is that hospice is dependent on families to provide the caregiving, and the intensity of this caregiving increases exponentially in the last weeks or days of life. And families can really feel heavily burdened by the demands of caregiving. The hospice benefit doesn't cover room and board, and so that caregiving load and the required resources are really put onto families or caregivers of the patient, and consequently they will experience a high level of financial and emotional stress. So these barriers prevent people at the end of life from receiving care that aligns with their goals, and that goal might be to not die in the hospital or in a nursing home, but to be at home and cared for by loved ones. So with that introduction as a foundation, I'll now shift to describing how a group of clinicians I'm part of developed a new program in our community to address an identified problem commonly experienced by a population of people at the end of life. So for some context, I'm located in Monterey County, beautiful county along the coast of California. It's the 17th largest county in California with 58 counties in the state. So our population is about 438,000 people. The median household income is 91,000 a year, but this is really a high cost area. And so people need much more for, to make much more than that to afford living here. About 12% live at or below the federal poverty level. And the majority of the population, 60%, identify Hispanic or Latino, which is higher than the state's population. 10% are without health insurance. So this next scenario really it's loosely based on a patient that really inspired a local hospice nurse when she went to visit her and identified the problem that she really wanted to address. And so this was part of that inspiration. This is Penny, who's a 77-year-old female with pancreatic cancer living alone in a studio apartment. She has a history of bipolar 2 disorder and generalized anxiety. She enrolled in a local hospice agency and discussed goals of care. She fiercely expressed that she did not want to go back to the hospital, especially at the end of life. She quickly became weaker and needed more help, but had no resources to hire a caregiver and no friends or family to call on. The hospice nurse assessed that she could no longer safely stay at home, and so she had to be transferred while actively dying to the hospital to receive care in those last days of her life, and she died at the hospital. So the hospice nurse really identified if she had a place to be where she received safe living environment, where she received around the clock caregiving, she wouldn't have had to go to the hospital. She was really staunchly against. So from that, a local group of local clinicians, including this hospice nurse in that experience, came together to really discuss how we could improve care of life, and really inspired by this central message of the quote that the provision of equitable care at the end of life, especially for marginalized populations, is a serious public health issue requiring community action and involvement. And this group is our physicians, palliative care physicians, hospice doctor, palliative care pharmacists, hospice nurses that really could see the need in our community. So the hospice benefit that was enacted in 1982 really provides an incredible resource for those at the end of life, but it doesn't fully address the issue of caregiving and housing that's necessary to receive quality hospice care. So it was this grassroots efforts to improve the problem, which was a lack of critical resources for this population receiving hospice care. Really looking at how we could provide housing and caregiving for people at the end of life and addressing it through social determinants of health, housing, poverty, and lack of health insurance, which would cover care. So through these efforts, we learned about the Social Model Hospice Home, and we established Jerry's Place. Jerry's Place is namesake is Dr. Jerry Rubin, who was a beloved local oncologist who actually historically his advocacy contributed in the early 80s to establishing the Medicare hospice benefit. So it's named after him. And Jerry's Place has 2 rooms that we lease at an assisted living facility. And it's dedicated to people that are enrolled in a medical hospice agency and who lack safe, stable housing and or adequate caregiving. So the social model hospice home concept may be new to some of you. So what it is a place for the dying, especially for those lacking an appropriate physical environment to receive hospice care or lacking stable caregivers. Sometimes it's called a community home or comfort home, but it's whatever that the name is for it. It's fundamentally grassroots in nature. It's coming from the local community and it's for the local community. And it complements what already exists in the community. So it's not seeking to replace or replicate services, but augment what is there and provide that gap in care. So for our colleagues identified 7 defining attributes of a social model hospice home. It's that they're a dedicated home. Residents receive around the clock individualized end-of-life care. It's an option when dying at home becomes unmanageable. It collaborates with medical hospice services, doesn't replace them. It's operated by a nonprofit organization, which is funded through community philanthropy, and it provides a supportive environment for loved ones. And it also includes community volunteers. This chart from a publication by Grant and Scott differentiates the medical model hospice that's provided in the home or in the inpatient facility from a social model hospice. And so as you note some of these differences, you'll see that the social model hospice isn't applicable to Medicare reimbursable care. So that's why it really relies on donations or grants from the community to operate. And this resource really aims to improve population health through making end-of-life care equitable for all, especially those from marginalized populations like the unhoused or those without available or adequate caregiving. It also can mitigate the significant financial distress that families experience from a terminal illness. It can mediate dysfunctional or disruptive family dynamics. And most notably, it's honoring one's values, goals, and preferences for their final day's care. So to clarify for our particular social model hospice, Jerry's Place is a multi-agency collaboration. So we don't operate an independent home. We've really developed this unique model where we partner with an assisted living facility. So we are a dedicated space. We lease 2 beds from this assisted living facility. And at the moment, our primary funding is through a large grant from the Hospice Giving Foundation. And then our nonprofit is Jerry's Place Foundation for Cancer Care. That's what operates Jerry's Place. The timeline for our development was actually rather quick. Some social model hospice homes can be years in the making, but we started about 3 years ago in the summer of 2021, really discussing the issues and potential ways that we could address the problem, really knowing we needed a dedicated space, but not quite sure how to afford it or develop one. And then we started looking at the social model hospice as a potential model. We applied for and we received our initial grant through the Hospice Giving Foundation and admitted our first resident in December of 2022. And then in September 2023, we opened our second bed, and we've continually operated with those 2 beds. And currently going forward, we're really looking at fundraising and then planning for another location. This is a photo of the outside of Jerry's Place at the assisted living. That door goes into 2 rooms, and then there's a shared bathroom. Our admission criteria aligns with those defining characteristics of a social model hospice, and also with other social model hospice homes. So residents can be enrolled in any of the medical hospice agencies in our community. We are not partnered and will never be with just 1 or 2 that we'll take residents from. It's really any hospice agency in our community. The prognosis, as we know, is never exact, but residents have had an estimated prognosis by a physician that knows them from either 2 weeks to 2 months. So it's really for those last weeks of life. They also have limited or no caregivers and really no other housing option. And then their symptoms are able to be managed outside of the hospital. So otherwise, if they weren't able to be managed, they would be more suited for that general inpatient care. So because we're multi-agency collaboration, this chart just helps to understand the organizational structure and the process of how we operate. So the nonprofit organizations, Jerry Rubin Foundation, has a board of directors. It has the executive director, and then we have 2 paid staff positions at Jerry's Place. It's a foundation coordinator and then a program manager. And then there's community volunteers that visit the residents at Jerry's Place. And then the assisted living staff has the regulations and the staff that provides around the clock care. So it helps with, they help with activities of daily living, they administer medications, anything that another resident would receive. And then the medical hospice agency staff provides care as they would if the resident was at their home. So nurses visits, assessments, family support, to volunteers. So all of that regular support that they would give. So since we opened in December of 2022, we've had 19 residents. They range, in age from their 50s to the 90s. The average age was about 74 years old. The most common diagnosis has been cancer, so it's about 8 out of 19. But we have other diagnoses, such as congestive heart failure, neurological conditions. And our overall goal is that we're providing housing and caregiving to people at the end of life who are receiving hospice. And ideally, this is at no cost to the person or their family to really address that social determinant of health poverty or the lack of reimbursable care. Our primary objective to really look at if measuring the success of our program is that we're achieving a 73% occupancy rate of those 2 beds every calendar year. So any program, especially new ones, needs ongoing evaluation. So we've identified these metrics so far to kind of track and address where we're at, looking at satisfaction from stakeholders, the number of days the beds are occupied, and how long a resident stays. So just looking at one of those for our occupancy rate, we've actually surpassed our aim of 73%. You can see when the rate for one room and both rooms, but the average across both of them, the vacancy rate was 11%. So what we found really is this is a needed service for the community. So here's an example of a resident that has come to Jerry's Place. This was a 73-year-old woman diagnosed with end-stage cancer. So her discharge from the hospital was complicated due to the fact that she lived alone. And she had family, but her family could not provide around-the-clock care that she required. So she was really hesitant to accept hospice and enrolling in a hospice agency until someone offered her Jerry's Place as an option. So she enrolled in a local hospice agency and she transitioned from the hospital to Jerry's Place. And at Jerry's Place, she received care from the assisted living facility staff and she received the medical hospice care from the agency. And Jerry's Place volunteers came, they provided music therapy and support as she came to terms with her prognosis. And then her family was able to spend quality, focused time being with her. Because the caregiving was taken care of, they could actually be with her. And she died 16 days after admission. This story was broadcasted on the local news and it's publicly available and recorded, but in that story, her daughter said, "I don't know what we would have done. She required care that was beyond our capabilities. But at the same time, we didn't want her to be in the hospital and not really have that dignity and that support that she was looking for. And the options were very limited down here. Jerry's Place has become part of our family." So in closing, we've had time to reflect over the past 18 months of operating Jerry's Place, and we really can say with confidence that it is a viable option for addressing the gap in services. It not only provides a room and caregiving to a resident, but we've seen that it allows residents to spend time with their families. And as they face this experience of imminent death, they have less stress because it's not in the caregiving burden and it's not in where they might go next. It's somehow allowed them to have this space and time. We also have found that the community support for Jerry's Place is overwhelmingly positive, which then reinforces that it's a needed service. We're working on a process for how to transfer residents when they outlive their prognosis of 2 months, which we have a couple that have done, and they've been successful transfers, but how we can find suitable housing for them and partnering with our hospice agencies in doing that. And then we're also considering how to develop this fair and equitable pay scale model so that we can have financial sustainability. And then lastly, our long-term plan, or really our dream, is to open a freestanding facility, which would be able to expand our capacity. Omega Home Network is a wonderful organization that ties these homes in the US together. And it's an essential resource, especially if you're thinking about the social model hospice home in your community. It really provides this information bridge to facilitate your grassroots efforts in your community to improve end of life experience and to educate communities about living well through dying. And this map shows the red showing developing homes, and the blue is where there's homes already established. And these are my references. I'll turn it over now to Barbara.
Thank you, Alyssa. So my discussion is going to pick up where Alyssa left off to some extent. There has been an awful lot written about goals of care, palliative care, care at the end of life, and particularly exploding in the last few years. And I also, in addition to wanting to continue with Alyssa's very fine list of references, just to add a few to that, to see what's been done out there about our current research on goals of care discussions and the importance of those at the end of life, but also to explore just a little bit and a few examples about DNP students. And, DNP students are always looking for some kind of a hot topic to explore, something that they're passionate about, something that they're interested in, that they can use as a vehicle for that capstone project that they're required to complete. And my own experience, I have seen students in the DNP programs really wanting to explore this and seeing the need in the community to be able to explore this. So first, just a little bit about the literature. I just did a quick search in CINAHL, looking just in the last 2.5 years. And there were over 2,500 published scholarly peer-reviewed journal articles on this topic. Goals of care discussions and goals of care conversations have been around for a very long time. Actually, I saw back in PubMed all the way back to 1967. And when I looked in PubMed without any year restrictions, there were close to 30,000 citations on this topic. And then I took a look at DNP projects in ProQuest, and there were close to 1,000 published DNP projects on this topic, on goals of care conversations, end of life care as well, and palliative notwithstanding. So lots and lots of published work. This is just one of them. I have a couple that I want to showcase with you. And the title of this one by Comer et al., Identifying Goals of Care, just says it all. I mean, how do we get at them? This short quote from the paper, Goals of Care Conversation should explore values, goals, and treatment preferences, kind of sets the stage for this discussion. And I'm calling these competing interests. They really shouldn't be competing, should they? Providers have some skin in the game, certainly family, and most of all, the patient. And how those goals of care conversations come to be, I think, is, even though it's been fairly heavily written about in the past 10 years, and going back to 1967, getting at those goals of care conversations in real time can really be a challenge for the family, a challenge for the patient, and certainly a challenge for providers. My dad passed away in 1996, and it was really very painful for us and for the family. He had spinal cord compression. He had prostate cancer that had metastasized, and he had surgery. But then we were rather assured that they didn't get everything, but not a whole lot of what that meant. And when he started having seizures, My mother called the PCP and on a weekend, and she did get an answer, but of course his answer was there's not a whole lot we can do for him in the hospital, but no conversation with my mom at all about hospice or palliative care or how can we make him more comfortable and what can be done. And it wasn't until I had a conversation with the PCP and said, well, what about hospice, that he said, oh, that's a good idea. But that conversation, we were looking for the provider to get that thing started, and he obviously was looking for us. And I think fast forward to 2024, I think those conversations are still hard to happen. And so just wanted to share a little bit more about this paper and a few others. So these authors provide a really nice framework that they put forward in terms of how those conversations come to be and how that discussion is perhaps on a continuum and changes over time. And, your goals may be for a cure initially after a diagnosis, but, as treatment options start to wane in terms of their effectiveness, being cancer-free may not be a goal. And maybe there's no terminal illness, but, God bless my 99-year-old mom who is, still with us, although she has absolutely no ability to perform activities of daily living independently. She still, we want her to be safe and happy, and maybe she'll make it to her 100th birthday, maybe she won't, but nonetheless, the goals of care conversation are all around safe and happy, and not necessarily about being free of disease and being able to manage in curing this. I mean, she's 99, and moving forward, that might be a real challenge. So taking a look at all of these factors, and I'm in New Jersey, my mom's in Connecticut, my brother and sister-in-law are close by, but they don't live with mom. So Alyssa talked about inequities of care at the end of life, and mom wants to be able to age in place, and fortunately Connecticut has a program through their Medicaid that allows her to do that, and we made that application and we were successful. Talking to my colleagues in New Jersey who are on the front lines of patient care, those options are not the same in New Jersey. So California found a solution that Alyssa presented with Jerry's Place. And there are Omega network places all over the country, but they are just emerging. So those inequities are very, very real. And you can see it play out not only in the literature, but also in the nature of DNP projects. So here's another paper that was published by Ho et al. And they talked about differences in goals of care discussion between various healthcare professional types. And this particular paper wanted to see if there were discussions that were led by nurses versus physicians. And it was interesting because it was a small sample, but there were some retrospective chart reviews in about 200 charts. And there was an educational process with both the physicians and the nurses who were involved in this, and also triggers for those conversations that were in the electronic system that they were using. And one of the results that I thought was very interesting was accepting CPR was more likely in a nurse-led goal of care conversation discussion as compared to physicians. In patients with severe comorbidity, no other differences in patients with mild or moderate. So I thought that was a little bit of an interesting study as well. And one more study before I move on to 2 DNP projects. And this was early involvement in palliative care and advanced care planning improves quality of life outcomes and survival for patients with advanced lung cancer. And again, goals of care, communication, and this was a paper that was published out of Australia, and it only included physicians, although physicians and nurses were included in the training. And physicians attended a communication skills course and again had a priming intervention for patients with advanced lung cancer who were managed in an outpatient setting. And there was in this paper an audit with goals of care completion in terms of the form. And it was a little disappointing in that only 1% of the patients discharged were working, were using the apps that they introduced. And, you know, as all things happen in these types of evaluative projects, this was a quality improvement project. And one of the things that they found was that there was a competing problem with the EHR during the 12-week project implementation. So it may be the case that those goals of care conversations were really happening. They just didn't get documented appropriately in the medical record, which you can see is a reality and a situation that our caregivers, our providers and nursing caregivers need to deal with almost continually. So this is another one. This was a DNP project that was focused on a clinical practice change out of rural Florida. And this project did see an uptake in palliative care referrals and were able to reduce the 30-day readmission rate by about 13%. And they also did, in this project, there was a very specific goal of care conversations that were available for documentation, once again, in the electronic health record. And they found that process to be successful.
Wonderful. Thanks so much, Barbara and Alyssa, for an excellent and informative presentation. We'll go ahead and take some time for questions now. Just as a reminder, if you have any questions, please make sure to type them into the question box or the Q&A box on your control panel. The first question was, this was related to something, Alyssa, you were talking about, which was, are they governed by the same rules in terms of medication administration as assisted living, such as the PRN pain medications and being able to place a MACY, M-A-C-Y, catheter?
Yeah, so it depends on the scope of the care, you know, obviously the state regulations, but for Jerry's Place, because we lease with an assisted living facility, the pain medications, catheter assessment is all within their laws and regulations. So for Jerry's Place, we aren't, we're not doing that care, so we don't have the laws and regulations. But if we had our own independent facility, then yes, you have to look at the scope of the care and then what laws and regulations would apply.
And I just wanted to add there was another question in the Q&A box that was about where Jerry's Place got its funding from, and Alyssa responded and said it's the Hospice Giving Foundation.
Yeah, Hospice Giving Foundation gave the initial grant and has funded another year, and we've applied for a third year. But for that initial grant is what got us started. And then over, you know, the last year or so, I see another question that applies on the sustainability and growth plan.
Yeah. Yeah, one of our other Springer authors, Mary Lynn Knighton. Hi, Mary Lynn, has asked, grant funding is a great start, but what is the sustainability and growth plan?
Yeah, so it's having multiple places in, getting grants from private organizations, also having, fundraising events and having small donations from the community. And then also, as I had looked at, or I talked about our pay scale model, so we're really committed to having it be no cost for those who can't pay, but there are models of homes that look at, what's the daily cost, and then how they could subsidize that, and then what it may cost for the families. So, that's what we're looking at right now. And then I see another question about regulations for the individual hospice agencies. Right. So those regulations would be for the hospice agencies and the care that they're providing.
Great. The next question we had was, is there a wait list for Jerry's Place? And how has that worked out in the day-to-day operations?
Yeah, so what's interesting is the wait list is in flux. So our program manager reaches out to our discharge planners at the hospitals, our contacts with the hospice agencies, and the physicians, and we'll have maybe a potential resident that may be appropriate. And when a bed is open, then she'll reach out to everybody to let them know. So we don't have a long wait list. We have notes of people that could be potentials and then following up with them. So over time, it's really just constantly checking in with our community stakeholders. And then, when a bed opens up, having maybe a sense of the next person, but sometimes that may change, and then reaching out to somebody else. So the wait list has been harder to really, it's not like a wait list where you could just go to the next person that's on the list, because things change.
Right. And then I guess the flip side was another question. Have you had any patients exceed the 2-month prognosis? If so, how did you handle that? And how did you communicate with partner hospices and residents about the potential they may exceed the 2-month criteria?
Yeah, so that's been another learning lesson of developing, what that process would look like, because we have had a couple people that exceed the 2 months. And in certain cases, what we've been able to do is work with the hospice agency social worker that will find, maybe another bed for them. Like sometimes a nursing home bed, a Medi-Cal bed, in our state would open up where they could be accepted to, and then we transfer them. So we definitely do not have, where we're kicking people out when they reach 2 months. That would never be part of our process, but it's really in conversation that if it's looking like somebody may need, they may need somewhere else. So Jerry's Place is really designed for, the last few weeks to maybe 2 months. And so if somebody's exceeding that, they may be more appropriate somewhere else. And it's just in partnering with the hospice agencies to find somebody. But we've had somebody who didn't have any other option and had stayed for a few months with Jerry's Place.
Great. The next question is Jerry's Place a licensed facility?
No, Jerry's Place, because we are multi-agency collaboration, we do not We do not have licensing. Sorry, I got a text from our program manager that really in those, the two that we've had that exceeded 2 months was really like a win-win discharge because we had resources that came together and we had people navigating for them, that it actually ended up being a very successful outcome in those cases. And it's from Jerry's Place being involved and helping to navigate. So back to our model, being at an assisted living and having a medical hospice agency provide that medical hospice care, those agencies have the regulations. Jerry's Place comes in more as a space, and then also helping to navigate the family.
Great. The next question is for Barbara. Barbara, can you clarify the study that you mentioned concerning CPR? Was the result that patients wanted to keep CPR as an option when the conversation was nurse-led versus physician-led?
Yes, absolutely. That's exactly what the results showed of that study. And I'm not exactly sure what the details were, but the patients were definitely inpatients for a particular purpose, and they made that decision to choose the CPR option when the conversation was held with the nurse as opposed to the physician. So can't explain why, but there was that observation and that outcome in that study.
Great. The next question we had also was for Barbara, which is, what is the PC screening tool, and is there a link to it that you can share?
The palliative care screening tool?
Yes.
I don't have access to that, and it wasn't included specifically in that study that I presented. I did have a student who used a screening tool for palliative care, and I could probably look and find that for you and find out what was used, but I don't have it from this particular publication.
Okay, thanks. The next question we have was for Alyssa. Do you think Medicare hospice benefit should cover room, board, and caregiving for people at the end of life?
Yes, I do. I think that, as in my presentation, that I think it creates a inequity when people don't have that caregiving that is really reliant on quality hospice care. So I do think there could be an discussion on how to expand that reimbursed care. One thing, though, being part of the Social Model Hospice and Jerry's Place, is there's something about it being more peer and providing from the community this care and connection. And I would hate to see, if it was, through the hospice benefit, having it be a for-profit agency or changing this landscape of care. I feel like there's somehow that care and comfort that's coming from a genuine desire to provide that to people at the end of life is transformative. So I hope that answers the question.
Yeah, it does. And then the next question is, if I'm interested in exploring a social model hospice for my own community, who should I reach out to, or what resources are out there?
I would say Omega Home Network is the very first place to go. It is such a supportive network that mentors people interested. It's a members type of network where you can have access to resources. You can visit other homes, and there's becoming more published in the literature on social model hospice. There's more research being done to look at its effectiveness and outcomes. So first going to Omega Home Network, and then in the literature, there's a few, which I've listed some of those publications in my reference list.
And I just wanted to take the time and say, it looks like we've covered all of our questions. And I want to thank everyone for spending the time with us today. And thank you again to Alyssa and Barbara for the great presentation. So I wanted to just obviously thank again Alyssa and Barbara for a great presentation. And if anybody attending today or listening to the recording of this is interested in purchasing the book, their new book is Population-Based Nursing, 4th edition, and you can receive a 25% discount using the discount code webinar24 at checkout on springerpub.com. Again, a reminder that the recorded session will be available on springerpub.com within 5 to 7 business days. And I want to wish everyone a great afternoon. And we thank you again, Alyssa and Barbara. And we look forward to all of you joining us in the future for future Springer Publishing webinars. Thanks and have a great day.